Respected chairpersons, just I will check, sir. Okay. Respected chairperson, I would like to express my deep gratitude to GVK sir for giving this wonderful opportunities. Sir, so my anxiety is only over the time. So Dr. Arun Raghavan donated 2 minutes. Actually, he spared 2 minutes for me. So kindly give me 12 minutes for me. Even I can take the discussion part 5 minutes. So 17 minutes probably. Okay, fine, sir. I think that the hyponatremia, actually, நம்ம லவ் பண்ணிகிட்டு இருக்க பொண்ணையே கல்யாணம் பண்ணால் எப்படி இருக்கும் அந்த மாதிரி லவ் பண்ணிகிட்டு இருக்கிற அந்த சோடியத்தையே 20 இயர்ஸாக நான் லவ் பண்ணிகிட்டு இருக்க சோடியத்தையே இந்த டாப்பிக்காக கொடுக்கும்போது எப்படி ஃபீலிங் இருக்கும். ஆனால் சோடியத்துக்கு இன்னொரு லவர் உண்டு, அது என்னங்கிறது நான் சொல்கிறேன் உங்களுக்கு, சரியா? Okay, let us begin with the case study because I thought that going through the complicated process of sodium pathophysiology, so many intravascular compartment, let us begin with the case study, I think, which will enlighten all kind of hyponatremia. So 65 years old male patient, a known type 2 diabetes mellitus, underwent muscle checkup. He is asymptomatic. His serum sodium is 128, potassium 3.8, 102, 20. Okay. If any patient presents with hyponatremia, we always look at 2 clinical parameters and 4 lab parameters. So what are the 2 clinical parameters? Whether patient is symptomatic or not symptomatic. Symptomatic hyponatremia warrants aggressive treatment. Asymptomatic hyponatremia may not warrant any aggressive treatment. Sometimes it requires no treatment at all. Point number 1. And second one, any patient who presents with hyponatremia, please assess the volume status. Whether he presents with volume overloaded state, I mean epidural edema and elevated JVP, basal crepitations and pleural effusion, or he is in euvolemic status, or whether he is in hypovolemic status, like probably mild thirst and hypotension, tachycardia, cold clammy skin and mental confusion. So first of all, any patient who presents with hyponatremia, assess the symptoms, the severity, and look at the volume status. So this patient really asymptomatic, okay. So what is the, I told the 4 lab parameters you have to look for hyponatremia. The first most important lab parameter is serum osmolality. Very, very important. Please take it very carefully. All very useful points I am going to offer. Any patient hyponatremia, without any hesitation, order serum osmolality. So what is serum osmolality? Serum osmolality is 282, normal value is 280 to 295. This patient has 290. So what is serum osmolality? Okay. Yeah, this slide is the most important slide you are supposed to focus. Please consider that this is blood vessel. Okay. So see, any organ is cut. If you view the organ microscopically, you can find one blood vessel. Adjacent to the blood vessel, you have cells. In between the cells, you have interstitium. This is blood vessel. Adjacent to the blood vessel, you have cells. Okay. So these cells constitute, the cells constitute intracellular compartment, all the cells. So almost our 80% of total body water is well sequestrated within this intracellular compartment. This intravascular and the interstitium is collectively called, other than cellular, so it's called extracellular compartment. So what do you mean by serum osmolality? Serum osmolality, probably it may be a work term, so when you read Genang or Gaitan during our student era, I try to simplify it. Serum, what is serum osmolality? Serum osmolality is nothing but serum contains solutes, which is nothing but positive charged cation, sodium, potassium, calcium, and anions, chloride, phosphate, chloride. Then you have something called urea and glucose, collectively called serum osmolality. But what you have to remember that 90% of your serum solute concentration is determined by your serum sodium. Even though you can list out so many solutes in the plasma, 90% of your solute concentration is contributed by serum sodium. For all practical purpose, for us, serum osmolality is synonymous with serum sodium concentration. If somebody says that hyponatremia, then I will immediately sense that there is decreased serum osmolality. If someone says that there is decreased serum osmolality, I won't think more than hyponatremia. So hyponatremia is nothing but when there is hyponatremia, then you will have decreased serum osmolality. What is the most important consequence of serum osmolality? When somebody has serum sodium of 112, that means naturally your serum osmolality comes down in the intravascular compartment. When osmolality comes down, the most important consequence would be the water content of the plasma will move from intravascular compartment into the cells. So what happens? Cellular edema occurs. The most important consequence of hyponatremia is cellular edema occurs in all the organs across your body. So all the organs are able to adapt cellular swelling other than the brain. Since brain has been encased within the rigid structure, so-called cranium, brain is not able to expand horizontally, so it will be forced to expand down. That is called coning, then it will lead to cardiorespiratory arrest. So that's why most of the time hyponatremia produces neurological symptoms only because of this. Because hyponatremia causes reduction in serum osmolality, then it produces cerebral edema. So I think that I am running short of time. Okay. So what about, as I told you earlier, when you look at hyponatremia, what you will think? Decreased serum osmolality. So in this patient, what about the serum osmolality? So we expect less than 280, but this patient, how much serum osmolality? 290. That means normal serum osmolality. So when we expect decreased serum osmolality, normal serum osmolality if somebody maintains, then probably the patient is in pseudo hyponatremia. So when somebody presents with hyponatremia, do serum osmolality, you expect reduction in serum osmolality less than 280, but if you find normal serum osmolality or more serum osmolality, think of pseudo hyponatremia. The most important causes would be patient may be harboring hypertriglyceridemia or hyperparathemia, for example, multiple myeloma, that you have to think. So this patient, 50 years old male patient, came with the complaints of breathing difficulty and pedal edema. Is a known case of dilated cardiomyopathy. Routine investigation reveals sodium. So this patient presents with hyponatremia. I told that whether patient is symptomatic, asymptomatic. Patient doesn't have any neurological symptom attributable to hyponatremia. Point number 1, eliminated. And second one, I told you volume status. What about the volume status here? The patient presents with pedal edema. So this patient hypervolemic hyponatremia, more volume. So what is the importance of hypervolemic hyponatremia? So hypervolemic hyponatremia, where your sodium concentration remains normal, the excess water that dilutes your body sodium, resulting in hyponatremia. So rather than addressing or focusing on replacing the sodium, if you find any patient hypervolemic hyponatremia with volume overloaded state like chronic, all organ failure like nephrotic syndrome, decompensated liver disease, cardiac failure, if you find hyponatremia with volume overloaded state, you remove the excess water, sodium will automatically get back to normal. So remove that excess water with loop diuretics, your sodium concentration will get back to very normal. Then another important is, in most of the hyponatremia, see, even though we say hypervolemia, what happens in all organ failures, it is not true hypervolemia. So in fact, most of the fluid will be sequestrated in the interstitium. See, all the organ failure, what happened? They will harbor edema. Edema means most of the fluid diverted into the interstitium. So intravascular volume will be less. So ADH will be more and more stimulated in hypervolemic hyponatremia. So any organ failure, they will have more ADH stimulation. ADH causes more water absorption. More water will come into intravascular compartment. Since they harbor organ failure, whatever fluid absorbed by ADH will be diverted into the intravascular compartment. Again, you will have intravascular depletion. So the first most important treatment for hypervolemic hyponatremia is you have to suppress the ADH. That's where you have, there is something called V2 receptor antagonist. Tolvaptan, the famous brand is Natrice. So the most important thing is hypervolemic hyponatremia, suppress the ADH. Suppose somebody presents with diarrhea and vomiting, there true hypovolemia occurs. There ADH stimulation there also occur, but there ADH stimulation would be beneficial. Did you get my point? In hypervolemic hyponatremia, whatever fluid absorbed by ADH will be diverted into interstitium. But in hypovolemic hyponatremia, diarrhea, vomiting, whatever ADH is stimulated, that is beneficial because that fills up the intravascular volume. Your BP will be elevated as a compensating mechanism, where you should not suppress the ADH. So, the tolvaptan is contraindicated in hypovolemic hyponatremia. On the other hand, in hypervolemic hyponatremia, it is indicated. And another important point, urine spot sodium. This another, I told 4 investigation. One, serum osmolality. You do serum osmolality, expect decreased serum osmolality. If there is normal or high serum osmolality, rule out pseudo-hyponatremia. Then another important is urine spot sodium. What is the importance of urine spot sodium? If you do urine spot sodium, if it is less, so less means what happens? Our body try to absorb the sodium very avidly. That means there is hypovolemia. So hypovolemia, that means the patient either harbors diarrhea, vomiting, something like true hypovolemia, or false hypovolemia like organ failure. Any patient who presents with urine spot sodium, what you have to think of? There is some form of hypovolemia, either true hypovolemia like diarrhea and vomiting, or false hypovolemia like organ failure. So normally what we expect, urine spot sodium is less than 12. If urine spot sodium more than, see now urine spot sodium we will divide whether it is less than 20 or more than 20. Less than 20 means there is hypovolemia. More than 20 means only 2 causes. Either the patient is on thiazide diuretic or SIADH. So any patient hyponatremia, do serum osmolality. If it is low, true hyponatremia. Then do urine spot sodium. Urine spot sodium less, there is hypovolemia. Either true hypovolemia or false hypovolemia. If urine spot sodium is more, 40 or 50, think of thiazide diuretic or SIADH.
So, sorry to interrupt, can you have the last slides?
Yes, sir. Okay.
Conclusion
Okay,
slide.
sir.
So, time
Problem
is
with
up
the
for
slides,
us.
sir.
Time is up.
Okay, 1 minute.
So, we have to,
Oh, sorry.
you can conclude the slide.
Okay.
Summary and take home points.
Yeah. So 40 years old female patient admitted with the complaints of extreme tiredness, easy fatigability. Okay, fine. So serum sodium 117. What is the first investigation? First investigation? Serum osmolality. Serum osmolality 256. Whether it is true or false. True hyponatremia. So you can rule out or pseudo hyponatremia, hypertriglyceridemia, hyperparaproteinemia, hyperglycemia, mannitol, so many things. Then do urine spot sodium. Less than 20 means there is hypovolemia. More than 20, that means I can rule out diarrhea and vomiting. There's no hypovolemia at all, or otherwise there won't be any sodium in the urine. Okay, there is no hypovolemia. Then that means more than 20 means 2 causes. What are the 2 causes? Thiazide diuretic, SIADH. So this patient presented with thiazide diuretic induced hyponatremia. How will you differentiate thiazide diuretic and SIADH? Do serum uric acid. If uric acid is very low, then it is SIADH. If uric acid is normal or high, thiazide diuretics. So with that, I would like to conclude.
Thank you.
If you have numerous doubts, then you can contact me. This topic warrants at least 1 hour discussion. I think that may not be possible here.
Thank you for the